Hello everyone, my name is Casian Roman. I'm a DDS and an MSc in Perio, and today I want to do a case review on 3D vertical bone augmentation in a complex period-restorative case. So I would like to start my presentation with a citation that I've read long ago about change. And the main question is, why do we change? And there are three main reasons. The vision is changing because we see a better way. The consequence is changing because we see what's coming tomorrow. And unfortunately, most of us wait too late. And when we wait too late, the only driver of change is pain. And at the end of my presentation, I will explain why. So we have a female patient with aesthetic and functional concerns. She's fit and healthy, no medical condition. She's a non-smoker. She's currently non-engaged in her oral health, and her upper PFM implant-supported prosthesis with previous sinus augmentation was done 5 years ago. She has functional problems because she can't chew on her right side, and she has mobility at the level of upright 6, 5, and 4 implant. So we move on to the intraoral status, and we have soft tissues with thick phenotype and areas of thin phenotype. We have a generalized gingival inflammation and generalized interproximal attachment loss, also generalized soft tissue recession. At the level of hard tissues, we have calculus deposits supra and subgingivally. We have a highly restored dentition. We have generalized staining and a non-carrier cervical lesions at the level of lower left 2 and lower left 5. So the patient problems, subjectively, we have bleeding gums. We have post-discharge at the level of upper right 5 and upper right 6, and we have discoloration in the lower anterior area. Objectively, we have generalized deprobing depths, the generalized attachment loss, and a PFM poor marginal adaptation with the overhangings. Moving on to the periodontal chart at the baseline, we can see that we have 84% of sites with the PPD equal or more than 4 millimeters. Also, we have a plaque score up to 91% and a bleeding score up to 89%. The baseline radiographic assessment, we can see that we have a generalized horizontal bone loss pattern between 30 and 100% in the maxilla and 10 and 60% in the mandible. We have internal root resorption, furcation radiolucency, infrabony defects at the level of lower right 3 and lower left 3. We also have the upper right 4 with vertical bone defect up to 60%, upper right 6 and upper right 5 with vertical bone defect up to 100%. We also can see minimal residual bone height at the level of upper right 6 and 5, and a sinus membrane that's irregularly thickened due to chronic inflammatory changes. With all of that information, we move on to the diagnosis. And according to the clinical decision-making algorithm, so since you have clinical attachment loss more than 5 millimeters, we have bone loss up to the middle third, we have history of periodontal tooth loss, we have hopeless teeth, we have a severe ridge defect, and the need of complex rehabilitation, we classify this case as periodontitis stage 4. Moving on to the grading, because we have a bone loss to age ratio more than 1, we classify it as grade C. So we have a patient with periodontitis stage 4 grade C, and we start our treatment into a state-wise approach according to the clinical practice guideline. We also assess the prognosis according to Pork and Caton. We take into account the periodontal, restorative, and endodontic considerations, and we classify the upper right 6, 5, and 4 as hopeless, and we plan to restore them with implants. Also, the rest of the dentition have a prognosis ranging between questionable and unfavorable. Next, we move on to our treatment planning, and we divided our treatment into 4 stages. The first one is case presentation, non-surgical periodontal therapy, upper right 6, 5, and 4 implant removal, and immediate implant placement at the level of lower left 7, lower left 5, and lower right 6 and lower right 7. The first reassessment, after 2 months, we perform a second session of non-surgical. Then we continue with restorative and endodontic treatment, a free gingival graft at the level of lower left 3, a free gingival graft at the level of lower right 4 and lower right 7. Then we perform our 3D vertical bone augmentation in the upper right quadrant, and the prosthodontic treatment of the upper and lower arch. The second reassessment after 8 months, we continue with our implant placement at the level of upper right 4, 6, and 7. And the last reassessment, after 14 months, we will perform a peri-implant soft tissue augmentation, the prosthodontic treatment of upper right 4, 5, 6, and 7, and then we will tailor an individualized supportive periodontal program for our patient. So the goals of our therapy is to reduce the level of inflammation to a BOP of less than 10%, is to reduce and maintain the plaque score of less than 20%, and reduction of the size with the PPD of more than 4 millimeters. Also, the idea is to restore the function, is to improve the smile aesthetics, and to replace the missing or hopeless teeth with the dental implants. So we start with the case presentation. At this stage, we inform and motivate our patient about the need and importance of oral hygiene and plaque control. Next, we move on to the cause-related therapy with subgingival instrumentation, with scaling and root planing, with the aids of ultrasonic devices and curettes. The next stage is the implant removal. And now we can see the granulation tissue, the bone particles from the previous sinus augmentation, the soft tissue defect, and a complete lack of keratinized tissue on the buccal side, and the implants extracted. The first reassessment, after 2 months, we already can see that we greatly reduce the inflammation level up to a BOP of 37% and a plaque score up to 60%. Here's the intraoral reassessment after 2 months. And even if our clinical endpoints of the therapy have not been met yet, it is extremely important to continue with our periodontal treatment because, as we know from the studies done by Mombelli, that the microflora present in the oral cavity before the implantation determines the composition of a newly establishing microflora on our implants. But also, according to the literature, this process can take up from 2 months up to 1 year. That's why we continue with 1 more session of non-surgical periodontal treatment, and then we will already continue with restorative and surgical treatment as we already greatly decreased the level of our inflammation. Next, we perform a free gingival graft at the level of lower free. We can see a complete lack of attached gingiva in that area, so the idea was to decrease the muscular tension and increase the area of firmly attached gingiva, so to stabilize it and to prevent it against the further recession after our prosthodontic treatment. The same situation at the level of low right 4 and low right 7. We performed an apical reposition flap, a free gingival strip technique. We stretch everything with the idea to reduce the mobility in that area and to stabilize it. Next, we perform the radiographic assessment of a defect area in the upper right quadrant. And we can see a very thin bony plate, mainly consisting of previously augmented bone, and a combined vertical and horizontal defect. And when I see this type of defects, I inevitably ask myself, is it possible to regenerate this type of defect? How risky is this kind of surgery? How much predictability I can present to the patient? How long will the treatment last? And how many surgeries it will require? And answering these questions requires a careful approach when interpreting the evidence. That's why we must use the method where the clinician uses the best available evidence, understand his own skills, and discuss it with the patient in order to make the best treatment and to increase the predictability. And as in our case, the main goal is to improve the predictability. We must follow sound biological principles and recreate a perfect area. I think it's falling. We must recreate a perfect area where the biological process can run, and in the end bring our restoration in harmony with the existing dentition. Now we assess the defect area, and we can see that since we have a history of previous sinus augmentation, we have an area mainly consisting of xenograft, and because we know it's reduced in vascularity, and that's why we have a higher chance of failure in this area. So that's why I decided to perform the gold standard in bone augmentation by using the autogenous bone graft. So I use the Curie technique with three-dimensional vertical alveolar ridge augmentation, but with some slight changes because I use the vestibular shifted flap proposed by Luca de Stavola. Now we can see the image draft right after the surgery. And the next reassessment, at 8 months, we can see the situation intraorally. Now, it's time for our implant placement. We assess the bone quality and quantity, and we can see that we have an average of 8 millimeters of vertical height. So I plan on placing 3 implants, MegaGen Any1, 4.5 on 8.5, and combine it with the osteodensification protocol, especially in the upper right 6 area, where we have only 7.2 millimeters. So we open the flap, we assess the bone quality, we place our implants, and unfortunately, during the implant placement, one of the blocks was a little bit displaced, but it was still attached to that area, so I decided to leave it there and close everything up. Here's the situation right after the implant placement. And the last reassessment, after 14 months, we can see that we already greatly decreased the level of inflammation up to 13%, the plaque score up to 31%, and we have just few sites with the PPD of more than 4 millimeters with bleeding on probing. So here's the panoramic reassessment after 14 months. We can see the cross-sectionals with implants in place and completely covered by bone. And now we have to face another challenge, the soft tissues. And we have a long history of evidence regarding the importance of soft tissue around the dental implants. And now when we want to make a decision, we can follow the latest osteology consensus report on the importance of keratinized tissue around the dental implants, where it is stated that the standard of care to increase the width of the peri-implant keratinized mucosa is a combination of the apical reposition flap along with the autogenous soft tissue grafts with an efficacy of up to 6.5 millimeters. And why it is important for us as clinicians? Because we must pay a particular attention to the establishment of a proper peri-implant mucosal seal around our implants if we want to achieve a long-lasting and stable result. Now, the peri-implant soft tissue augmentation. We performed an apical reposition flap. We harvested our three-gingival graft on the palate and sutured it on the buccal side. Then we placed our healing abutments in place and sutured everything up. Now we can assess the soft tissue quality and quantity before the impression taking. The individualized zirconium abutments in place and the final prosthesis delivered. Here we can see the evolution of a smile that completely changed the look of our patient. The reassessment of the intraorals at the baseline, at the reassessment after 2 months, at the reassessment after 8 months, and the reassessment after 1.5 years. Here's the panoramic image at the baseline and at the reassessment after 18 months. And the last step, we assess the periodontal risk assessment, the implant disease risk assessment, and we performed a personalized supportive periodontal program for our patient. In conclusion, the journey we embarked on today with this complex period-restorative case serves as a powerful reminder that change is not merely an option, it's a necessity. And as I leave you with that thought, remember, we must not wait until pain becomes the only driver of change in our practice. Instead, let's be proactive and follow the evidence and strive to prevent complication and deliver the best care for our patients. Thank you.